We are glad to have you all again in our fourth webinar during this academic year, and we promise you with much more to come, inshallah. As you know, our main goal is to enhance and enrich our academic journey with webinars, research projects, and much more. We would like to thank Prof. Abdul Jabbar, Dean of College of Medicine, Dr. Asiri, Vice Dean, Dr. Ashrbini, Supervisor of the MMSC, and all the MMSC members for their continuous support and efforts. Of course, we would also like to thank Dr. Waqar for his collaboration and acceptance to hold the webinar. We will be taking any question and discussion at the end of our webinar by writing in the chat box or clicking the raise hand option kindly. Last 15 minutes. For those who registered and wanted to receive certificates, please make sure to write down your name as in the registration form. Wish you a joyful time with us. Now I will leave you with Dr. Waqar.
Assalamu alaikum and good evening. Can you guys hear me?
Yes,
Hello?
we can hear you clearly.
Okay, good. And can you see me clearly? Because I want you, I mean, it's not that I'm interested in showing my face, but I just have a paper during the lecture which I will show you. So I want like a clear focus for that. So can you see me clearly now?
Yes, doctor.
Okay, good. Again, welcome everyone. Assalamu alaikum and good evening. It's a pleasure when our dear doctor called me and asked me to present this one. Although it's not my topic, I've never taught this before in Maarifa, but again, as you know, I love teaching, so I just quickly sat and read a little bit and prepared a simple lecture for you, keeping in view that you guys are not postgraduate, undergraduates. So something basic we will talk about, and I hope you find it easy and how to apply this in clinical practice. So first of all, how are your vacations going? Hello? Hello?
Yes, doctor, the students are unmuted now.
Yeah, no, but can they hear me?
Yes, they are hearing.
Okay, so no, I want to know how are the vacations going, everyone? Hello, yes. Okay, we'll proceed with this one. Can we please change the slide? Today we'll talk about anemia. Okay, first of all, what is the definition? Basically, of course, we know what is anemia. In simple common terms, it's low hemoglobin. But the correct definition of anemia is decrease in the RBC count. The number of RBCs becomes less. And this, of course, will cause low hemoglobin and hematocrit, right? So according to correct definition, what is anemia? It is a decrease in the RBC count, which causes, in turn, low hemoglobin and hematocrit. These are the normal values of hemoglobin. In males, less than 13 gram percent, and in females, less than 12 gram percent. So 10, 11, that is also anemia. And of course, the lower you go, the more serious the problem becomes. Next slide, please. Now, what are the common presenting symptoms? How will a person with anemia present to you, and what will be his or her complaints? The complaints are very non-specific. Weakness, of course, there is less hemoglobin, which means that less oxygen will be supplied all over the body. When the tissues have less oxygen, then you get all these problems: weakness, fatigue, becoming tired easily, lethargy. Lethargy means fatigue, feeling tired all the time. And even with small, depending again on the severity of the anemia, the person will say that, oh, before I used to walk very nicely for 1 kilometer or half kilometer. Now I get tired, even if I walk a few sort of yards or steps. But again, as I said, the severity of these symptoms depends on how severe the anemia is. So these are the commonest presenting features. The second common are headache, dizziness. Dizziness means doha. And tinnitus means like a buzzing or ringing sound in the ear, Zzz, like this. So this can happen often, many times, off and on. And of course, as you see, the weakness, fatigue, lethargy, they are so non-specific. Thousands and thousands of diseases can present with these problems. So as a clinician, of course, when we know many diseases, then we know how to approach or how to deal with this person. So whenever anybody has these complaints, think of the common things first. And one of the common things is anemia, which causes weakness, fatigue, and lethargy. What are the signs which, like, on physical examination, which you will see, of course, paler, what we call pallor, pale conjunctiva, and oral mucosa, because low hemoglobin, of course, causes less, the purified blood, too much is not going into the tissues. So the best place to check for pallor is the conjunctiva and the oral mucosa. Of these two, the better one is the pale conjunctiva. Having said that, again, that also depends on the severity of anemia. You may have many patients with hemoglobin of 10, let's say, which according to definition is anemia, but you may not see too much pale conjunctiva. So the more severe anemia, the more pallor you will see. Nail pallor, the nails usually normally are pinkish, right? And when you press on the nail, if you can see me like this and then release, they become white and then it refills. So nails also lose the red or pinkish color, they become pale. Koilonychia, again, is not specific for all anemias. It usually happens in iron deficiency anemia. So, but these are the things which you may sort of see. Again, iron deficiency anemia does not mean always you will see koilonychia. So symptoms and signs are important, of course. In any disease, you have to take a history, you have to sort of see for the signs. But in case of anemia, due to any reason, in a patient with anemia, these are important. But the most important thing in anemia is laboratory investigations. Because as I said, the person may have iron deficiency, but without any koilonychia. Koilonychia will happen only in severe anemia. And koilonychia, if you remember, what is that? It is spoon shaped. Normally, if you can see my nail, it is convex, like curve is up. Koilonychia is concave, like a depressed nail. So that happens in severe iron deficiency. Of course, there are some other diseases also which can cause koilonychia. So you check for koilonychia in a person with anemia, then the nails become very brittle. Brittle means very easily breakable. Brittle things are like, when you, like the girls will be knowing it if they do cooking, spaghetti. When before cooking, when you see spaghetti, you press it and it breaks. So we say the spaghetti is very brittle. That is how the nails become. They're very brittle. A little pressure and they start falling. They start breaking. So that happens also again in severe anemia, any kind of anemia. Then tachycardia and systolic murmur. This can happen in any anemia. Whenever there is loss of hemoglobin and RBCs from the blood, just think of it like this, that normally we have a certain amount of hemoglobin and RBCs in the blood, and the blood is flowing very nicely. When there is lack of RBCs, the RBC amount becomes less. Just imagine or just think that the blood becomes more dilute, right? Just like watery. When there is more RBCs, it becomes a little thicker. So now we have anemia, so the amount of RBCs is less. So the blood becomes, you can imagine as if the blood becomes more thinner and dilute. Whenever this happens, it leads to the rapid flow of blood. The flow of blood in the blood vessels is very fast. It is flowing faster as compared to normal. This causes tachycardia, and that is why plus tachycardia, and you hear a systolic murmur if you listen over the heart valves, usually the mitral, but anywhere. So this murmur which happens in anemia, it is a systolic murmur, but it is not pathological. It is what we call a physiological murmur. There is no problem in the heart valves. If the anemia gets corrected, the blood before it was a little dilute, now the amount of RBC improves after treatment, the fast flow of blood becomes normal. So this tachycardia and systolic murmur goes away. So in a person with anemia, if you hear a murmur, think of that it could be because of anemia. Of course, another patient may have anemia with valvular abnormalities, but just keep this in mind that a systolic murmur can happen, and it is a physiologic murmur. It is not pathological. The other, which is a relatively common thing in anemia, is glossitis. Itis means inflammation, and gloss means the tongue. Gloss, thickening sometimes of the tongue, it's happened. So this means inflammation of the tongue. So if you see the tongue of that, sometimes it will be reddish, or it will be like a smooth, not the regular papillae. So that denotes that the tongue is affected. But again, depending on the severity. Among these, the commonest is pale conjunctiva and oral mucosa, nail pallor, and tachycardia. Okay, next slide, please. Now, those were the findings which we usually see in generally all anemias, tachycardia and pallor and all, of course. Some anemias, of course, may have certain specific findings on examination, so that you have to do a thorough examination of the abdomen and look for certain things. For example, some anemias may have splenomegaly. and the spleen may be enlarged. On the contrary, some anemias may have splenic atrophy, which means the spleen becomes smaller. Any idea which anemia causes spleen atrophy? Anyone? Hello?
اللي يبغى يجاوب can write on chat.
Okay. Can they speak the answer or no?
دكتور, they can speak after the webinar إن شاء الله.
Okay. So yeah, sickle cell, very good. Sickle cell anemia causes atrophy of the spleen. Okay. Because in the long term, I mean, we will not go into details of each anemia in this lecture. So let's leave that topic, that how splenic atrophy happens. But sickle cell patients, in the long run, the adult patients, after many years, the spleen becomes atrophied. And some other anemias, splenomegaly can happen, like all hemolytic anemias, more chances of splenomegaly. Next slide, please. Okay, now keep in mind that anemia can happen either acutely or it can develop slowly over time, what we call chronic anemia. Acutely, anemia can happen how? Let's say if someone has a car accident, too much blood is lost. So it's an acute problem. It didn't happen over many days or months or weeks. So that can cause anemia, which is like an example of an acute anemia developing immediately, shortly. And slow anemias are all like, iron deficiency and all the others which we have read in the books. So they develop slowly over time. So that's why we call them, they are chronic anemias. Now, point number two, if anemia develops acutely, of course, there are more chances that the patient will have symptoms. Because let's say today I'm very healthy. Let's say I have a hemoglobin of 13. So my body is used to it. Suddenly I lose too much blood, and from 13, the hemoglobin goes to 10 or 9. So my body is not used to it. So sudden changes, when they happen in the body cannot tolerate. So I will have symptoms more, right? I will feel dizzy, doha, and feeling tired. How, on the other hand, if the anemia is chronic, which most of the anemias are, like iron deficiency or sickle cell disease, they happen slowly over time, so that as the RBCs are going down, the body is also trying to compensate and do something. So that is why chronic anemias usually, at least to a certain level of hemoglobin, they don't produce too much problem. You will not see sickle cell patients having all the time problems that, feeling doha and this and that. They come with acute crisis when that happens. So because the issue is that due to the chronicity of the condition, the body has adapted to it. Anything, that can happen, anything. If any disease is acute, it causes more problem. That is why if anemia develops acutely, there are more chances the person will have symptoms. However, if you see the last point, more chances of symptoms if hemoglobin is less than 7, whether it is acute or chronic. So let's say I'm saying that chronic anemia, more chances that your symptoms will not be too much because your body has adapted. But if your hemoglobin goes very low, let's say less than 7, 6 or 5, then you will have symptoms even if it is chronic. Because of course the body has adapted to a certain level. Beyond that, it's not that, okay, hemoglobin 2, no problem, body has adapted. So 7 is a critical number below which symptoms almost always happen, even in chronic anemia. And that is why in most of the anemias, the criteria for transfusion is also 7. For example, sickle cell. Most of the patients have sickle cell disease have chronically low hemoglobin, around 8 or 9. We don't transfuse them, okay, because they are asymptomatic. Their body has adapted to that hemoglobin of 8. They will not have any doha, this and that. But when these patients with sickle cell, the hemoglobin drops less than 7, then we always transfuse. And most of the time, even if they are not having symptoms. So let's say if someone with sickle cell disease comes with a hemoglobin of 5 or 6, we will transfuse, even if they are not having any symptoms. So 7 is a critical number, generally speaking, below which we always go for blood transfusion. Next slide. Okay, so now we know that we have taken a very good history, and we did the general physical examination, and we know certain points. What are the investigations which we should do in any patient with anemia? I have just numbered them 1, 2, 3, 4, 5, 6, 7. It doesn't mean that you have to do all in every case. It depends on the clinical, what is your assessment after the basic tests. So the first is CBC. Number 2 is reticulocyte count. In short, we will call it retic count. 3 is peripheral smear. Then we have bone marrow biopsy, hemoglobin electrophoresis. Again, as I said, in certain anemias, not all. Then we do LFTs in certain suspected anemias. We will talk about that quickly, which anemia we should do what. And the number 7 is serum haptoglobin levels. I will tell you what it is. So one by one we will go. Now, the commonest things which are done, the first thing which you do in anemia, the lab test is number 1 and number 2. You have to do CBC and retic count. And then most of the time, the peripheral smear also should be done. So 1, 2, and 3 are a must in almost any case in the beginning. Because these 3 things, of course, can we go back, please? Back? Because these 3 things, 1, 2, and 3, the first one will, of course, you have to do. It will tell you whether there is anemia or not. Retic count will help you in something which I will tell you, and the peripheral smear. Then number 1, 2, and 3 will give you quite a good idea which type of anemia the person may be having. And according to that, then you decide whether you need to do 4 or 5 or 6 or 7. Okay, so 1, 2, and 3 are the must in any case. Next slide, please. Okay, CBC we'll talk one by one. Very quick points. It's not a very detailed or confusing lecture. This, of course, CBC will tell you about hemoglobin, hematocrit, MCV. MCV means corpuscular, means cell volume, which is it is a number actually on the CBC which tells you about the size of the RBCs. Normally, there's a certain size of the RBCs. If the RBCs are smaller than that, MCV will be low. It will be a number. If the RBCs are bigger in size, MCV will be high. The second, also you will see on CBC, MCH means cell hemoglobin concentration. This is the concentration of the hemoglobin inside the RBCs, which of course will be high or low depending on the anemia. There's another thing on CBC which is called RDW. It is called red cell distribution width. Now it's a very little confusing for you guys at this level, so don't try to go into the detail. If you want to look up in the books, no problem, but it gets affected in many anemias, especially in iron deficiency anemia, it is high. Okay, I don't want to go into the details and explain what is RDW, blah, blah, blah. It's a technical thing. So let's forget about it. Just know that RDW is something, it is a number. It is written in the CBC and it is usually high in iron deficiency. Then, of course, the CBC will show you the platelets and the WBCs also. So this was the first thing. So in an anemia, hemoglobin, hematocrit will be low. Next slide, please. The second thing is retic count. Very important, and we should know what it is. Now, reticulocytes are normally also, we have in our blood reticulocytes, a few reticulocytes in the blood. Reticulocytes are basically immature and early forms of RBCs. You know that all the cells of the marrow, WBCs, RBCs, and platelets, the first beginning cell is the stem cell, and then it divides into pro-erythroblast and this erythroblast and that erythroblast, and then finally erythrocyte. So reticulocyte is one of those cells, the earlier form of RBC. Normally, of course, RBCs are being produced in our body, and most of the RBCs come in the blood. Some of the earlier forms like reticulocytes and all, they may come in the blood. So you will see a few reticulocytes in the blood in normal patients. And the normal retic count, what we say is 1 to 2%. So let's say if you have 100 cells in the blood, 100 marrow cells, WBCs and RBCs and all, 1 to 2 will be reticulocytes also. So that is normal. Now, what happens is that, and of course, as you know, the cells are produced in the marrow. Now, retic count is high if anemia is due to loss of RBCs like hemolysis or blood loss. What happens is that if somebody is having hemolysis, the RBCs are being formed in the bone marrow, they are coming in the blood, but in the blood, they are getting destroyed too fast, much faster than normal, right? Now the body realizes, the marrow realizes that, oh, the cells are all going out. At this point, Dr. Waqar should have, let's say, 100 cells in the blood. There are only 50 cells left because of the hemolysis. So now the bone marrow starts quickly becoming active, wants to produce RBCs very faster. So the bone marrow becomes hyperactive. Whenever the bone marrow becomes hyperactive, of course, more RBCs will be formed and they will come in the blood, but some earlier forms of the cells will also spill into the blood because now the bone marrow is much hyper than normal. That is why in hemolytic anemias, whenever there is destruction of the cells or there is loss of RBCs outside the body, like blood loss, the bone marrow gets a signal, it becomes hyperactive and starts producing cells very faster. And that leads to more RBCs coming out and also more retic count. On the other hand, point number 4, if the main problem is in the bone marrow, then of course the bone marrow cannot become hyperactive or active. So that is why the number of all the cells which are produced, including RBCs, WBCs, and also retic count. So retic count is low if anemia is due to disease of the bone marrow itself, because retic count, the reticulocytes and all the cells are coming from the marrow. So retic count gives you, immediately after CBC, the first thing you do, it gives you an idea if the problem of anemia is in the bone marrow, or if the problem of the anemia is not in the bone marrow, but it is outside the bone marrow. So in that case, if the problem is outside the bone marrow, the retic count will be high because now it is hyperactive. If the main problem is in the bone marrow, the retic count will be low. So that at this step, the basic test, and it's a very simple test. Every Mustasaf and every simple clinic, they can do it very easily. It's not a very fancy test. So this test in the beginning gives you an idea. So let's say if someone comes to me with low hemoglobin, CBC, okay, then I do a retic count low. So now I can say that, yes, now at least I know that this patient does not have anemia because of hemolysis. There is something problem in the bone marrow, right? So this is how retic count helps you. Next slide. Peripheral smear. Now, CBC is when you do CBC, the nurse takes the blood, puts it in the tube, and they put in the machine. And the machine just gives you a printed paper. It gives you the numbers. You are not looking at the cells. Peripheral smear, you can look at the cells. You take a little blood, put it on the slide and observe under the microscope after adding all the additives and all. And there you see the WBCs and RBCs. That is called a peripheral smear. Here you see, number 1, here you see the blood film under the microscope. Of course, you can see the RBCs, the WBCs, the platelets and everything. And in that, you can see many things. If the RBCs are normal, if they have abnormal shapes, or certain abnormal shapes of RBCs, which are called schistocytes, which we will see what it is. Then teardrop cells, these are another abnormally shaped RBCs, teardrop cells. And spherocytes, are small, circular, and like abnormal RBCs, which are smaller, circular, and they are not biconcave. Normally, RBC is biconcave, which means that on top and on the other side, it is like a C shape. Spherocytes are convex, small, circular, but convex. So they are called spherocytes, like hereditary spherocytosis. So peripheral smear will show you the abnormal shapes of the RBCs. And also, my students who have done the lecture of this B12 deficiency and all with me, we've discussed that, in the peripheral smear, you see the big RBCs and B12 deficiency and all. So peripheral smear will show you the size of the RBCs also, whether they are normal shaped, normal sized, small or bigger. So this is how the peripheral smear is done. This can also be done easily, even in any Mustasaf or clinic, doesn't need a big fancy hospital. Next slide, please. Bone marrow biopsy, of course, you don't do it routinely. I mean, everybody coming with anemia, you do bone marrow biopsy, of course. People will run away from you, they will never come to you. But usually people admitted in hospital, under hematology, they are trying to figure out what it is. Then they go for certain diagnoses to find out what's going on. Then you can do a bone marrow biopsy in some cases, but it's not done routinely in every patient. And where do you do the bone marrow biopsy? You don't drill a hole in the femur or tibia like that. You just do it from the sternum. It's like I'm not sure if it's a general or local procedure, but a little like anesthesia and a little drilling in the sternum. From there, you can take the bone marrow, or from the iliac crest. So these are the usual 2 sites from where you do the bone marrow biopsy. Next slide. Hemoglobin electrophoresis, again, a little fancy test, not very much. I mean, most of the time, some big labs do it. Again, by the time you have done the CBC and retic count and peripheral smear, you have quite a big idea that what kind of anemia it is. And certain anemias you cannot diagnose without hemoglobin electrophoresis. So it is done in cases of suspected hemoglobinopathies. If the anemia is due to some problem in the hemoglobin, especially sickle cell and thalassemia. Now, sickle cell disease, of course, you can see this abnormal sickle cells under the microscope. But thalassemia, so you have to do hemoglobin electrophoresis. Without that, you cannot. Of course, it will show you anemia, thalassemia. It has a microcytic picture and all, but again, you cannot be sure. So thalassemia, of course, needs hemoglobin electrophoresis. In that, they take the blood, they run it in a machine, and that tells you if there is any abnormal type of hemoglobin in the patient, and that is the cause of anemia in that. So done in suspected cases. So if you are suspecting thalassemia in some patient, you have to order hemoglobin electrophoresis. And it gives you like a graphic picture, and it will report hemoglobin A is this much, hemoglobin delta 2 is this much, or F is this much. It tells you the different types of hemoglobin in that patient. So that is called hemoglobin electrophoresis. Next slide, please. LFTs. Now, LFTs you do again if you are suspecting hemolytic anemia. Of course, by this time, you probably have a good idea if the person is having hemolysis or not from the history, from the physical examination. He will have jaundice, of course, because whenever the hemoglobin is broken down in hemolysis, hemoglobin is converted by the body into bilirubin, okay? And bilirubin, which is an excretory product, and bilirubin makes your eyes yellow, which is jaundice. So if you have jaundice in the person, if the CBC then shows anemia and retic count, of course, now hemolytic anemia, as we said, the main problem is outside the bone marrow. So the bone marrow will become hyperactive. So in that case, in hemolytic anemia, it will try to produce more RBCs and more retic count. So retic count will be high. So you see a patient with jaundice, hemoglobin low, retic count is high. You are quite certain that, oh, I'm sure, most likely he's having hemolysis. Let's check LFTs, because LFTs then will show you high bilirubin, right? Can anybody tell me which type of bilirubin will be high in hemolytic anemia, direct or indirect? Type your answer, please, if you can, because there are two types of hemoglobin, if you know, direct, conjugated, what we call, and unconjugated, which is called indirect. Where, think about it again. Somebody wrote conjugated. Somebody wrote unconjugated. Very good. From Dr. Arshi, unconjugated. Again, we don't want to go into the details. Just quickly, I will tell you what happens whenever there is bilirubin is formed in the body, in the blood. It goes to the liver. In the liver, the bilirubin, which is just being formed from hemoglobin, it in the excuse me, in the liver, it combines with something to form conjugated bilirubin, which then comes in the urine and blah blah blah. In the blood, if there is too much hemolysis going on, the liver will try to conjugate that to some extent, but then the liver says that, oh my God, I can conjugate only 1,000 molecules. Now there are 3,000 molecules of bilirubin in the blood, unconjugated, which is still not conjugated. Now the liver cannot do anything. So the unconjugated level of bilirubin is high in hemolytic anemia. And then this conjugated hemoglobin, unconjugated, becomes conjugated in the liver. So now, because the main problem is too much production of bilirubin, the first bilirubin which is formed is unconjugated. So if you do LFTs in hemolytic anemia, it will tell you total bilirubin high, unconjugated bilirubin very high, conjugated will be maybe slightly high, okay, but usually normal to slightly high, but unconjugated will be very high. Next slide. Okay, what is haptoglobin? Before looking at this slide, I want you to just don't look at this slide. I'm going to show you something on the screen and tell me if you can see this. Can you see this, the paper which I'm holding? Just type, yes, okay. If you look at the top, okay, let me do like this, because this way you will understand it very nicely. Okay, just think that in the blood, we have something called haptoglobin, okay? It is a protein molecule. And here, if you can see, I have made about 10 haptoglobin molecules, round. So 10 haptoglobin molecules. And on the other side, I have made some hemoglobin molecules by X, 1, 2, 3, 4. Because of course, even normally we have a little free hemoglobin also. RBCs are being broken down, and the body is taking care of that hemoglobin which is released. It is converting into bilirubin, blah blah blah. But a little bit free hemoglobin is also mawjood or present in the blood. Free hemoglobin, which is floating free. But we don't want that, because free hemoglobin, if it is too much or little bit, it can damage many organs. So what happens is that normally, whenever there's a little hemoglobin in the blood, here I have 4 hemoglobin molecules, okay? Crosses. Can you see the crosses? Just type yes. Yes, okay. So 4 crosses. Now this is a normal situation. 10 molecules of haptoglobin with 4 free molecules of hemoglobin. What happens is that normally, this is what happens. Out of those 10 molecules of haptoglobin, 4 of them have combined immediately with hemoglobin. Haptoglobin is a protein which whenever it sees free hemoglobin, it combines with that. It says that, no, 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 I'm not going to let this hemoglobin free in the blood because it's going to damage the bodies. I'm going to combine with it. So haptoglobin immediately combines with the free hemoglobin, and then it gets metabolized or excreted or whatever. So now normally, let's say 4 of these molecules are used, you still have 6 molecules of haptoglobin in the blood, correct? And of course, more haptoglobin can be produced. Now, what happens in hemolytic anemia? Instead of 4 hemoglobin molecules, you have too much hemolysis. So you have too much free hemoglobin. Now, instead of 4, I have 10 hemoglobin molecules floating around. And these, they immediately combine with all the 10 haptoglobin molecules so that now you do not have any haptoglobin. Again, of course, it's not possible to have 0 haptoglobin, but let's say you have only 2 haptoglobin left. Normally you had, out of 10, you had 6 left. So now, because there was too much hemolysis, too much free hemoglobin came in the serum, and it combined, all of it combined with the haptoglobin, all the haptoglobin was used up. That is why what we say that in hemolytic anemias, the serum haptoglobin levels are low. Okay, that tells you that the anemia is hemolytic. So now if you read this slide, haptoglobin is a protein normally present in the serum. Whenever there is hemolysis, haptoglobin molecules combine with the free hemoglobin, and this is then metabolized. When there is excess hemolysis, all the haptoglobin molecules are used up. So of course, haptoglobin levels become low. So that is why we say in hemolytic anemias, serum haptoglobin levels are low. So whenever you see haptoglobin, if you are suspecting hemolytic anemia, you did the LFTs, then you can do haptoglobin levels, they will be low in case of hemolytic anemia. Okay, next slide. Now, classification of anemias. There are various or different ways of classifying based on the shape of the RBCs, based on this, based on that. The 2 common ones are, number 1, you can divide the anemias depending on whether the problem is in the bone marrow, which means that due to decreased RBC production, or the bone marrow is okay mainly, no problem, no main problem in the bone marrow, but there is excessive loss of RBCs, as we said, hemolysis or bleeding. That is one way of classifying, that either decreased production or increased destruction. Another way of classifying, somebody says that, okay, let's say Dr. Abdul Rahman says that, no, I don't like this classification. I want to classify anemias based on the RBC size. So that's another form of classifying. Like if my students remember, we did the megaloblastic anemia. We said normocytic like that. So some anemias have big RBCs, some have normal RBCs, and some have small. So you can classify anemia also based on that. And of course, every anemia can fit into both. So let's say in number 2, if I am saying on the size, I will say that, oh, I classified this anemia based on the size was small, so now it is microcytic anemia and it is iron deficiency. Now, iron deficiency anemia is microcytic, but if you want to classify iron deficiency anemia based on number 1, whether it is decreased production, so it will be decreased production. So each anemia can be put into both categories. It can be microcytic, small size, and in the other category of 1, it can be either hemolytic or usually due to decreased production. Okay, so these are the 2 ways of classifying anemia based on which you can say that this type of anemia or that type of anemia. Next slide, please. Anemias due to decreased RBC production. Okay, so right now, because our lecture basically will be based on that, which means that small. Now, of course, the RBC production in the main problem is now in the bone marrow, which means that the retic count will be high or low. Can anyone type? The problem is in the bone marrow. The retic count, what will it be in these anemias? Low, very good. Low, very good. Oh, mashallah, everyone, very low, good. So because the problem is in the bone marrow cannot do anything, so it cannot become hyperactive. So anemias which are due to decreased RBC production, retic count will be low. Low or low normal, depending again on the severity of the disease. It can be normal, but a little towards the low side. What are the examples? What are the types of anemia which are due to decreased RBC production? Number 1, iron deficiency, which is very common, folic acid deficiency, anything which is needed by the RBCs for production. So many things are needed by the bone marrow cells for production, like iron, then B12, folic acid, so many other vitamins and all those things. When they are deficient, it will lead to decreased production. So all those conditions can cause anemia due to decreased RBC production. The common ones I've mentioned here: iron deficiency, folic acid deficiency, and B12 deficiency. Then number 3, thalassemia. Thalassemia also, there is a decreased, what we call ineffective erythropoiesis. It is a genetic disorder in which there is production is also affected, plus there is also a little bit of hemolytic component inside the marrow. But it is not classified basically as a truly hemolytic anemia. We call it decreased RBC production, thalassemia, which is quite common, by the way. Number 4, anything problem in the bone marrow. Example, bone marrow is full invaded by cancer cells. Let's say you have any leukemia, white blood cell malignancy, or any other malignancy anywhere. Cancer cells can go anywhere and affect any part of the body. So now they have come to the marrow and they've infiltrated the bone marrow and replaced all the normal cells. So now the bone marrow is destroyed. That is also a cause. Bone marrow infiltration can happen by cancer cells. Or there's a condition called in which there's fibrosis. Fibrous tissue gets deposited in the bone marrow, which we call myelofibrosis. All the cells will be affected. RBCs, WBCs, platelets, everything. So that's a very serious condition. Number 5, damage to the bone marrow by radiation or chemotherapy. Many times people have radiation, means like, either radiation for cancer, it can damage the chemotherapy in the bone marrow. That's why many cancer patients need a sort of supportive therapy like IV, blood transfusions to maintain this RBCs. Or chemotherapy can also damage, any chemotherapy can damage the bone marrow. So chemotherapy or drug-induced damage to the bone marrow. Chronic renal failure also, there is decreased production of RBCs from the bone marrow. There is no destruction of bone marrow in chronic renal failure, but there is a deficiency of something in the body which is needed for RBC production. Some hormone is needed to stimulate RBC synthesis. That hormone is deficient or becomes low in renal failure. Which one is that? My students of medicine 1 should answer that. Which hormone? Yes, very good. Erythropoietin. Deficiency of erythropoietin. So that is why production of RBC is affected. So chronic renal failure also produces anemia due to RBC production. And of course, many chronic diseases not related to the bone marrow, usually rheumatological diseases, rheumatoid arthritis, SLE, and all these things, they have anemia due to multiple reasons, multiple factors, and those are called anemia due to chronic disease. Any chronic disease can lead to that. And of course, chronic diseases can have other things also. They can have iron deficiency, they can have folic acid deficiency, but then the anemia becomes a mixed picture. But what we are talking about is the chronic disease itself causing the anemia. Example of which is very common is rheumatoid arthritis. Next slide, please. So last one, number 7, another etiology of anemia due to decreased RBC production. Many times you will see this in hematological wards, what we call aplastic anemia. Aplasia means hyperplasia over, some tissue is hypertrophic or hyperplastic. Aplasia is opposite of that. Tissue very dead, almost dead, not dividing cells are not there, not active. So that is the opposite of hypertrophy or hyperplasia. Aplasia of the marrow can happen either due to damage to the stem cells of the bone marrow, stem cells which form all the cells, so they can get damaged. And that, of course, will lead to not just anemia, but also low WBCs and low platelets. So aplastic anemia patients will have all the cells low. Number 8, HIV patients can have anemia due to decreased production. Plus, of course, they can have other problems also which can cause anemia. And of course, any infections of the bone marrow like viral infection, CMV. CMV infection is very common in people who have poor immunity like HIV, people who are on immunosuppressive drugs. They frequently get CMV infection, cytomegalovirus. And this virus can affect anywhere in the body, eyes, brain, and also the bone marrow. So infections of the bone marrow, usually viral infections can also cause that. So these are number 1 to 9 are all the causes or etiologies of anemia due to decreased bone production by the bone marrow. Next slide, please. What will be the labs in most of all these anemias? The general labs. Again, certain things will be there in certain anemias. Of course, the retic count will be low or low normal. Like it will, when I put normal, it means that doesn't mean that totally normal, but towards the low side. But usually it will be low. Depending on, again, what is the specific etiology of this anemia, you will have other specific tests which may be abnormal. Example, if there is iron deficiency, you will do iron studies, serum transferrin and blah, blah, blah will be low. If that is due to low B12 levels, you will do B12 levels, which will be low. So those are the specific labs for specific type of anemia. Peripheral smear, of course, will show you the specific picture depending on, again, what the etiology is. In iron deficiency, you will see small RBCs, microcytic anemia. B12 deficiency, my students will remember, they will see big RBCs with a hyper-segmented nucleus like that, right? So students who have not done my lecture, of course, when you come, we'll talk about it, but don't go into the details at this time. But peripheral smear will show that. Sometimes, like, when the diagnosis is still 100% not clear, you may need a biopsy, especially in cases of bone marrow fibrosis and pancytopenia. So when you do a biopsy, it will show you fibrosis of the bone marrow in cases of myelofibrosis. Next slide, please. Okay, so that was one category. The second category, in the second type of anemia in the same category, we are talking about anemias either due to decreased production or due to increased destruction. Increased destruction means hemolysis, of course. These are the common ones. Sickle cell disease, there is hemolysis. Hereditary spherocytosis, another hemolytic anemia. Drug-induced hemolysis, many drugs cause hemolysis. Autoimmune hemolytic anemia, it's a condition where you have antibodies which are formed against the RBCs due to either no known reason or due to secondary to some other disease or blah, blah, blah. So these antibodies then destroy the RBCs, causing hemolysis. I think the numbering is wrong. 1, 2, 1, 2, 3, 4, what's going on? So anyway, G6PD deficiency, this you should know because it's quite common actually. G6PD is an enzyme. We will talk about it, a few points of that. That also causes hemolytic anemia and microangiopathic hemolytic anemia. You should know this because it's also quite common. We will talk a few words about this. Next slide, please. So generally, now we will not go into the details of sickle cell and this and that. That when you come to medicine, we will talk about it because right now our aim is to how to approach an anemia patient. What will be the labs in hemolytic anemias? Of course, we said that the main problem is not in the marrow, it is destruction. So the marrow will be hyperactive. Retic count will be high, of course. Increased bilirubin because too much hemoglobin is being produced. It is being converted into bilirubin. LDH is also high. LDH, remember, is an enzyme which is present in most of the cells, inside the cells. Whenever there is damage or destruction of the cells or even muscles, even the skeletal muscle and all, when there is destruction, everything inside the cells and muscles comes out in the blood. LDH is one of them. So now there is destruction of the RBC, so LDH is also high. But LDH, we don't, specifically do it. More important is bilirubin. Once before, long time, like, 20, 30 years before, they used to do LDH as a cardiac enzyme also because it is in the cardiac muscle also. So whenever there was myocardial infarction, all the enzymes from the cardiac muscle used to come in the blood, which is CPK and LDH. So LDH used to be done as a part of cardiac enzymes long time back, not anymore. Now though we just do CPK and more than that troponin. So LDH is high in hemolytic anemias also. And of course, I told you how the haptoglobin becomes low in hemolytic anemia. So among these, I would say the most important are retic count, bilirubin, and haptoglobin levels low. Haptoglobin, maybe every lab will not do. It's probably, I'm not sure how expensive it is, but again, it can be done. It's not like very, very expensive or something. Next slide, please. So those were the tests. So then we decided that, okay, this patient has hemolysis. We did that workup. It showed us high bilirubin, low haptoglobin. Then, of course, for certain specific anemias, you will do specific tests. For sickle cell disease, you will do something called a sickling test. That again, I will not go into the detail. It's a very quick test. It tells you whether sickling is sodium metabisulfite test, it is called. Then, of course, peripheral smear. If you do a peripheral smear, you will see the sickled shaped cells, like a crescent, like a half moon. Those cells you can see on the peripheral smear. And of course, the final thing you can do, hemoglobin electrophoresis, because in sickle cell disease, the main problem is an abnormal type of hemoglobin. So hemoglobin electrophoresis will tell you that yes, there is an abnormal hemoglobin, and the graph will come and they will say that HbS, hemoglobin S, is there in the blood, in the patient's blood. So that is specific for sickle cell disease. For thalassemia, as I said, it will show you obviously abnormal CBC, which will show you low hemoglobin. Thalassemia is a microcytic anemia, so MCV will be low. But if you only have CBC, anemia with microcytic, how can you be sure it is thalassemia? It can be iron deficiency also. So you may go for iron deficiency, but thalassemia, the confirmation is by hemoglobin electrophoresis. Now remember, thalassemia is very common in certain areas of the world, and especially in Saudi Arabia also, and many patients are totally asymptomatic. They don't have dizziness and this and that, and even sometimes the hemoglobin is not very low. It may be just a little, 11, 10.5, like that. So you will not see most of the patients with thalassemia, especially the people who are what we call trait, half thalassemia gene. So they will have hemoglobin of even around 11. So if somebody comes with me with a microscopic anemia, let's say CBC showing a little low hemoglobin, 11, and MCV is low. Sometimes we say that, oh, no problem, maybe a lab error. Hemoglobin is 11.2, not bad. No, don't do that. It could be thalassemia. So thalassemia patients can have almost the near normal hemoglobin also, 11.2, 11.5, like that. So if you suspect thalassemia that maybe the person's family has, go for hemoglobin electrophoresis. And many times I've seen patients whose hemoglobin was pretty good, 11.5, 11.2, but there was MCV was low, microcytic anemia. Then you go for hemoglobin electrophoresis, they say that yes, he has thalassemia, like, A or thalassemia, whatever. So thalassemia has to be diagnosed by hemoglobin electrophoresis if you see a little low hemoglobin with low MCV. Then we come for C, autoimmune hemolytic anemia. As we said, destruction of the RBCs due to antibodies which are formed due to any reason. And those antibodies can be detected by a test called Coombs test, direct and indirect Coombs test. Now, again, I will not go into the details how we do the Coombs test and this and that. That again, when you come to us, we will teach you. But Coombs test, somebody says that, oh, what's the Coombs test? So, like, let's say anyone asks Dr. Arshi, what's a Coombs test? So she will say, oh, Coombs test is a test, a blood test, which detects the antibodies against the RBCs. That's it. And there's a difference between direct and indirect Coombs test, but at this level, no need to go into that detail. And the students who have done Dr. Sufi's lecture, probably they will know about it. So the Coombs test can detect the antibodies which are directed against the RBCs. So that will tell you whether the person has autoimmune hemolytic anemia or not. Next slide, please. Okay, G6PD deficiency, you should know. It's very common. It's a type of hemolytic anemia. Normally, as the slide says here, we have an enzyme inside the RBCs called G6PD, glucose 6-phosphate dehydrogenase, blah, blah, blah. Don't remember the name. Some people have a deficiency of this enzyme due to some hereditary condition, like a Morusi condition, what we call. It is an X-linked disorder. So when people who are deficient in this enzyme, they are more prone to anemia. Not always, usually most of the time, they get hemolysis whenever they take certain medicines or they eat certain foods. So this anemia, this hemolysis depends on some foods or some medicines. So let's say I have, G6PD deficiency. So maybe some medicine, if I will take, I will get anemic, the episode of hemolysis, acute hemolysis, right? So that happens. And I will tell you in the next slide what causes that. So G6PD deficiency is a hereditary condition. It's an X-linked condition. So of course, more common in males because males have only one X chromosome. Any disease which is an X-linked condition will always become more common in males. It can happen in females if they have the abnormal gene on both X chromosomes, which is usually not so common, right? So X-linked conditions are always more common in males. G6PD deficiency is quite common worldwide, especially in Africa and the Mediterranean regions, which includes actually the Arab countries also, then Greece, Cyprus, and all those countries. Next slide, please. G6PD deficiency continued. Now, acute hemolysis happens in these patients when they are exposed to food. What food? So certain beans, it's a kind of vegetable called fava beans. Not all beans, but the most famous ones are fava beans. Or if these patients get any infection, let's say a person who has G6PD deficiency get pneumonia, any infection, so he can get acute episode of hemolysis. Or many drugs. Now, drugs are very common cause of acute hemolysis in these patients. There's a long list of drugs which can be a problem to these people, but the common ones I've mentioned here, which are the simple ones which you people should maybe also know, sulfur drugs, sulfur-containing drugs. Can anyone type any sulfur-containing drug, the name of any sulfur-containing drug? Some common one. What we call sulfur drugs. Anyone knows? Can you type? Okay, I'll tell you. Aspirin, yes. Salicylic acid, probably. I'm not sure. Yes. The other common ones are glyburide, I'm not sure. Sulfonamide, yes, exactly. The common ones are, the antibiotic Bactrim, trimethoprim sulfamethoxazole. That is a sulfa drug. Lasix, surprisingly, even I as a student did not know that Lasix furosemide is a sulfa drug. So anybody who has sulfa allergies, don't give these drugs to them. So those are sulfa drugs, and there's a whole list of these. So sulfa drugs are a problem in G6PD deficiency also. Primaquine is a medicine which my students of medicine 1 know. It is a medicine used in certain malarias to prevent relapse of the malaria. When you come to medicine 1, we will teach you. So that is also a problem. Always, whenever we are going to give primaquine to a malaria patient to prevent a relapse, always check for G6PD deficiency before, because primaquine can be a problem in these people. Nitrofurantoin is an antibiotic usually used for UTIs. That also, we'll talk about it when you come to Med 1. As I said that, G6PD patients, you will usually have problem when they are exposed. Yes, very good. Vivax and Ovail, Dr. Sultan Abdullah. Malaria. If the malaria is due to 4 types of Plasmodium, 2 types, Plasmodium vivax and Ovail. If it is due to that, you treat the malaria, and after that you give the drug primaquine to prevent the relapse. Otherwise, relapse will happen. So primaquine is used in those 2 cases, Vivax and Ovail. So what I was saying is that people with G6PD deficiency will develop acute hemolysis if they're exposed to one of these problems, infections or blah, blah, blah. Some patients who have severe G6PD deficiency, they can have alatul anemia, like a chronic anemia, even without any exposure to anything. Hemolysis is chronic and it occurs even without any triggering factor. So then, of course, maybe they are sometimes transfusion dependent, but usually they are a very low number. Usually the deficiency is mild to moderate, and they get problem when they are exposed to those things. And of course, G6PD levels can be easily checked. You just give a request to the lab that I want G6PD levels. So they will check it and they will give you the report that G6PD deficiency is there or not. Next slide. Microangiopathic hemolytic anemia. Now, before understanding this, it is also called in short MAHA. Now, this is an official short form, not mine, okay? So now, normally, you know that we have blood vessels in our body, big, medium, and small. Small blood vessels also do not have any problem. RBCs can pass through them normally, a little bit squeezing, no problem. When the smaller blood vessels get blocked by thrombus, many thrombi are happening throughout the body, like DIC, disseminated intravascular coagulation. That's a serious condition in which small thrombi are being formed inside the small blood vessels of the body, right? Now the blood vessel is partially blocked. The RBCs cannot travel through that blood vessel. While trying to squeeze, the RBCs get broken. So it's a kind of, you can say, hemolytic anemia, right? And the RBCs get broken and the shape also changes. This is what is called microangiopathic hemolytic anemia. It is a hemolytic anemia. The RBCs are getting hemolyzed. Why? Because the blood vessel, the angio, is pathopathic, angiopathic. There is problem in the blood vessel and it is micro. The small blood vessel is the problem. What is the problem? Inside the small blood vessel, there is some physical obstruction. Usually it is, as I said, in DIC, small clots. So that is why we call it microangiopathic hemolytic anemia. The RBCs cannot squeeze nicely. While trying to squeeze through that narrowed blood vessel, they get destroyed. So that's what I've written here, narrowing of the small blood vessels of the body. Example, clots are formed in DIC, or vasculitis. Whenever there is any vasculitis of the blood vessel, it becomes narrow and lumen. The RBCs have to squeeze through this to pass, and while doing this, they get destroyed. Now, the damaged and destroyed RBCs in this case are called schistocytes. Their shape changes. They get destroyed and their shape changes, which can be easily seen on a peripheral smear. Next slide, please. See here, the black arrows, those are schistocytes, broken and sort of deranged RBCs. They were trying to squeeze through the small blood vessel. Some of the RBCs are normal. So these are called schistocytes. Now, of course, that's the role of the pathologist to tell us the report. But this, you should know that exactly what schistocytes are and what are the conditions in which they can be seen. They can be seen in microangiopathy. So whenever the peripheral smear shows you schistocyte, it means there is some problem going on. Microangiopathic hemolytic anemia may be there. Next slide, please. These are the conditions in which you can see microangiopathic hemolytic anemia, DIC, malignant hypertension, which means severe hypertension, which can damage the blood vessels again, preeclampsia, again there is blood vessel damage, and of course vasculitis, which damages the blood vessel again. There's another cause of RBC hemolysis and damage, same picture like that, but it's not like a problem in the vessels. Heart valve. People have heart problems, valvular problems, and they have mechanical heart valves. Mechanical heart valves are like a metal thing. When the blood RBCs are passing through them, they can also get hemolyzed. So mechanical heart valves can also cause hemolysis, and they can produce a hemolytic anemia. So, but that's not microangiopathic. So just keep in mind that people who have mechanical heart valves, they can have hemolysis of the RBCs and anemia. Next slide. What will be the labs in microangiopathic? It is a hemolytic anemia. So of course, all features of hemolysis, which will be that retic count will be high, bilirubin will be high, and haptoglobin will be low, right? It's a hemolytic anemia. Plus, we said schistocytes on the peripheral smear. So you did the CBC, you did LFTs, and you did peripheral smear. You have a pretty good diagnosis, whether it is microangiopathic, whether it is like, other hemolysis. Of course, in other hemolytic anemia like sickle cell, you will not see schistocytes on peripheral smear, right? You will see the sickle cells. Next slides, please. Next slide. Anemia due to blood loss. Of course, you know that either blood loss can be acute or chronic. What are the acute blood losses? Usually car accidents and all like that, But chronic blood loss this is important. We should know as doctors. GI bleeding, peptic ulcers. Some people have very common. Some people have bleeding peptic ulcers. Now, if the peptic ulcer is bleeding too much, of course, the person will have gross blood. He will say that, oh, doctor, I'm vomiting blood, or my blood stool is black. But many patients with ulcer have very micro bleeding, small bleeding a little bit, which you cannot see by gross examination of the stool. If you check the stool, there will be blood positive. So that's a very common cause. GI bleeding from the peptic ulcer, colon carcinoma, very common cause in old people, especially in the West. That is why after a certain age in the West, it is a must to do stool for occult blood testing to rule out colon carcinoma, like a surveillance. So colon carcinoma, a very common presentation is blood in the stool, which can be microscopic blood. You cannot see. You have to just do a stool analysis. What are the other causes of blood loss in the GI bleeding? Inflammatory bowel disease, of course, Crohn's and ulcerative, very common. Angiodysplasia, I just mentioned this. It's actually a very common cause in old people, even in our parts of the world. Angiodysplasia, what is angiodysplasia? Don't go into the details. It's just like a vascular abnormality of the colonic blood vessels. The blood vessels of the colon inside the mucosa and all, they are sort of, they become big and tortuous and twisted like that, abnormally shaped, and they sometimes rupture and bleed. So it's quite a common cause of blood in the stool in old people, angiodysplasia. And of course, you have to rule out colon carcinoma also. So depending on what the person is presenting, usually you go for colonoscopy. The other very common cause of blood loss is menorrhagia in females. So a young female comes to me with anemia. Of course, I will ask this in history. Then the third one is blood loss in car accidents, which is of course usually always acute. I mean, nobody will say that, oh, doctor, I had a car accident and I'm chronically losing blood since 3 days. This will not happen, of course. So car accidents, usually motor vehicle accidents, will cause acute blood loss. Next slide, please. Now remember, in case of blood loss, don't think that, okay, somebody comes to me with car accident, very, in shock, blood pressure 90/60, too much blood lost. He will be in, in a very grave condition, but his hemoglobin, he will not show by blood test, he will not show anemia at that time. Why? Because blood has been lost, but the blood is now getting so much fluid is lost that the blood becomes concentrated. So hemoglobin level may be okay. So let's say 1 hour before the patient had accident, too much blood was lost and he comes to you. He may have very low blood pressure and he's drowsy and this and that, but if you check the hemoglobin, it may be normal. Okay? Don't be fooled. After a couple of hours, when the body starts retaining water from the kidney, because now the body wants to conserve water, too much blood is lost. That is the time when the anemia will be unmasked. It will become apparent. Then if you should do the CBC, then you will see the hemoglobin low because of hemodilution. Okay, so remember, acutely, the blood loss for a couple of hours may not show a low hemoglobin. Next slide, please. In conditions of blood loss, the marrow is initially active. then it leads to, okay. So this slide, I'm just saying that initially, whenever there is, let's say, blood loss or hemolysis, the bone marrow, of course, becomes active and tries to produce more RBCs to compensate. So, of course, you will have high retic count, just like hemolysis. But if you know there is alatul blood loss, let's say someone has colon carcinoma, which is otherwise silent. Alatul, small blood is going out from the colon carcinoma or from the peptic ulcer, which is alatul causing low hemoglobins from 12 to 11 to 10. The body is trying to produce, but he doesn't know it. He has never been to the doctor. A time comes when all the iron in the body has been used. The marrow was using iron to make more cells. So now the person will become iron deficient, right? So then, before it was due to blood loss from the peptic ulcer, the marrow was hyperactive, the retic count was high. But after many, maybe let's say a couple of months or 1 or 2 years, now the marrow cannot act more because now all the iron is gone. The person is not even eating enough iron because obviously all the iron is used. Now that anemia, which was due to hyperactive, the marrow was hyperactive. Now the marrow becomes underactive because it doesn't have the iron. So now it changes into that type of anemia. Got it? Which is due to decreased RBC production, and now you will see low RBC count. So the same person, initially there was blood loss, the retic count, if you check, it will be high, but he did not take any treatment, no iron given, nothing. Finally, when all the iron was gone, now the marrow cannot be active to compensate. Now it becomes, instead of hyperactive, the retic count, hypoactive, the retic count will go down. Got it? So that's the concept, that continued blood loss will lead to retic count going down. Otherwise, of course, blood loss is same hemolysis. It will lead to high retic count. Next slide. Another way of classifying anemia is based on the RBC size, as my students of medicine 1 know. Some anemias, if you do the peripheral smear or the CBC also, MCV will be low. They have small RBCs like iron deficiency and thalassemia, the most common causes of microcytic anemia. Macrocytic means big RBCs. Commonest causes are B12 deficiency, folic acid deficiency, alcoholism, and hypothyroidism also. Hypothyroidism, if you look up in the books, it can cause both, depending on whether the hypothyroid picture is more dominant or the person is having either iron deficiency, sometimes they develop iron deficiency, or menstrual irregularities in the female that can lead to microcytic. But technically, strictly speaking, hypothyroidism causes macrocytic anemia, the big sized RBCs. Some anemia is called normal size. The size of the RBCs is normal, it's just that the number of the RBCs is less. What are the examples? Chronic renal failure due to erythropoietin deficiency and anemia of chronic disease like rheumatoid arthritis. Next slide, please. Few points about drug induced. As we said, anemia can be, many drugs can affect the bone marrow and cause anemia, and there are different ways how the drugs can cause anemia. Some drugs, they directly suppress the bone marrow. They go to the bone marrow and destroy the RBC or destroy the WBC. So direct suppressive action of the drugs on the bone marrow. Some drugs, somehow they produce anti-RBC bodies. So let's say I take any medicine. Drug means like, not mukhadarat, right? We mean medicine. So I take some medicine. Due to that medicine, my body will produce some antibodies against the RBCs, and these antibodies will then destroy the RBCs, not the drug directly destroying the RBCs, okay? So that's another mechanism by which the drugs can cause anemia, hemolysis. And of course, some drugs can cause deficiency of those substances which are needed to produce RBCs. I've given you an example like folic acid deficiency. Now, folic acid deficiency, of course, there are many causes of folic acid deficiency, but there are some medicines also which by some mechanism they produce folic acid deficiency, which then produces the anemia. So these are the mechanisms by which different drugs can cause anemia. Next slide, please. And of course, the last slide is very important. Is that yes, please. Always my students of Med 1 and Med 2 know this. The last slide is very important. This is what is the result of using cell phone while driving. And I'm so happy that I think most of my students are following this, not you doing this. The group leader for Dr. Abdul Rahman, he said that, doctor, I did not take your call because I was driving that day. I was so happy with him. So please don't do this. These two things, even texting and mobile phone, absolutely no. So I never do this. I tell my students, please, please, please don't do this, okay? Because we don't, God forbid, God forbid, God forbid, we don't want to land up the first slide picture. Thank you very much and enjoy your evening. Any questions, please feel free. I hope you understood and enjoyed. just you can either raise your hand or type the question or whatever. If it's okay, then no, thank you very much. You are welcome. Yes, one thing more. You're welcome, all these doctors. Yeah, anybody wants this lecture, please take it from Dr. Abdul Rahman. He has a lecture, he can email you. And I hope it was helpful to you. You're welcome, Dr. Huda, Dr. Dej. Yeah, very, very welcome. Anytime. And you guys have any other medical question, anytime, you can just take my number from any of my students and just contact me. Because I love, you guys, when you ask anything which I don't know, it stimulates me. So then I read myself and then I try to, so I just love this. This is my, life, like reading and teaching my students. You're welcome, all of you, from Dr. Sultan, Dr. Muhammad Sankari, and very, very welcome, Dr. Arshi. Welcome, anytime. Anything not clear, very welcome, Dr. Amin Bashir. Thank you. How is my neck, Dr. Abdul Rahman? Well, the neck is better, but now the neck problem has gone into the right shoulder. So I'm getting physiotherapy for that. But alhamdulillah, it's better than before. But I've started a little, again, a little swimming, which I used to do before because my pool is now open after Corona. Get an ECG. No, please. My right arm. No, my left arm is okay. My right arm is bad. So no ECG, please. You're welcome, Dr. Abdullah Hassan Al-Khudairi. Thanks a lot, Dr. Sultan.
Thank you, Dr. Waqar, for this great and fruitful webinar. Your efforts are much appreciated. As the time has ended, I would like to thank you all one more time, our dear Dr. Waqar and attendees. Certificate will be sent via your registered email. However, it will require some time, so don't worry. The PowerPoint file will be also shared later. We should appreciate any comments, feedback, or suggestion through our email, Twitter channel, and Instagram account. We hope to meet you all next week during our art gallery at Alkharfi College, which will be held on 20 and 21 of January 2021. For further details, please check our social media channels. Thank you, Doctor.
Thank you very much. All of you have a good day and enjoy, and hope you like it. And inshallah, we'll continue this in future. Okay? Take care. Bye-bye.